Okay, so welcome everybody. Thank you all for your patience. I know some of you will probably quite happy it's online and join online often usually anyway, but for some of you it's not so good. I'm sorry about that. As you can probably hear, I'm not very well, but I didn't want to cancel the meeting, so we're going ahead, and this way no one wants to be in the room with a chair who's coughing and spluttering and the rest of it. So thank you very much for joining. I just need to use the usual technical stuff. I'm Councillor Lucia Dasneves for the benefit of the recording. I'm the chair of the Health and Wellbeing Board, and this meeting is being recorded for live and subsequent broadcast via the Council's internet site. The meeting is being held virtually, but we have some attendees in George Meehan House in person. Everyone else is online. So thank you very much for joining. And what I'll ask is that we don't do a round of introductions, but instead, when you speak for the first time, if you're presenting or even just asking a question, if you can make sure that you introduce yourself, please. Bosra, do we have any apologies?
Yeah, we've got apologies from Mike Carter, Anne Graham and Richard Gawley, and apologies for lateness as well from Lynette Charles.
Thank you very much. And are there any items of urgent business?
No, there's no items of urgent business.
Any declarations of interest?
Not that I've received.
Thank you. And I don't think we've received any questions, deputation, or petition, have we? In that case, I'll move straight to the minutes of the last meeting, which was in fact the 20th of September 2023. Are there any comments or notes, amendments, I suppose I should call them, to those minutes? No? Okay, well in that case, if everyone's happy, I will take those as a correct record of the last meeting, and we'll move on. The other thing to say is we've had to tweak the agenda a little bit, I'm afraid. So we're going to move item 9, the item about the Haringey Borough Partnership update, a little bit later in the meeting to be around the space for item 12, just to accommodate another meeting that some of the team are at. So we will go straight to item 8 now, which is the workforce update. Now, I know that Sarah was going to lead on this, but presumably not, because I know she's not very well either. Rachel, are you picking up this one? Oh, Cassie.
I'm very grateful to Cassie for picking this up, because the GP Federation, it also hosts the North Central London Training Hub, so she's really well placed to talk to it. Thanks, Cassie.
Thank you very much, Cassie. We're all dropping like flies.
No problems at all. And I will just share my screen so that you had these papers in the notes, but it's probably helpful just to quickly show you a few bits. And as Rachel said, we manage, so my name's Cassie Williams, I'm the Chief Exec at the GP Federation. We manage NCL and Haringey Training Hub, and Michael Fox, who's the exec for the Training Hub, has been working with Sarah to really think about our workforce needs a little bit in Haringey. So that's where this has come from. This first slide really highlights a few key bits of information for you all, and I think the goal for today is if anybody thinks there's anything really burning from a Haringey perspective that they haven't yet thought about, but just to confirm that really this has come from the fact that workforce, not surprisingly as a recurring theme as the borough partnership has been coming together, that we need to make sure that we are looking after our workforce, that we're developing our workforce, and that we're recruiting the right people. So we do feel like there's some real opportunities across our different partners to work together and to have some economies of scale. And we're making sure that in the integrated care system that has all of our wider health and care colleagues as part of it, that the knowledge and insights from there are feeding down into us and that we're able to feed up into it. I should also say we have recruited via the Training Hub somebody who can specifically work on this work. So he works for us some of the time he works for the Whittingtons, some of the time his name's Zach Buttle, so he's a workforce integration lead. So I shan't go into very much detail about this, but just to let you know, across NCL they have identified, partly based on national and regional stuff, they've identified 3 core areas of focus. One is to make sure that we are ensuring our supply of workforce, and we know in Haringey there's lots of work going on with organisations like Haringey Works, that we are making sure that we are seeing local workforce recruited through. Then there's development. This is partly about making sure we're developing our staff, we're providing them the right training, that sort of opportunity, but also looking after their health and well-being. And then the third area is around transformation. So we're always thinking about what are new ways of working, new models of care. In general practice, we've had lots and lots of new roles come into the workforce. But as we work more closely in partnership, we think about new roles and how we can work together. So I shan't speak to this slide because it just talks in more detail about the sort of work that is going on at an NCL level, but obviously happy to take any questions. For those who love governance, this is a beautiful slide. But the key points to say is, from a North Central London perspective, there's a people board. That people board helps drive the work that I've just described. But then in Haringey on the right hand side, you can see under the Health and Wellbeing Board, we have the Borough Partnership Executive. We have these different work streams, but the Neighbourhoods and Health Inequalities Board is where the workforce is sitting. And this is early days, but as they've started to think about really practical, what could we start to do now together to make a difference, they've identified 3 priority areas. The first is maximising entry-level recruitment, the second is a neighbourhood training offer, and the third is dissemination of workforce information. And so the next 3 slides, and again, I will assume that most of you, although I did see that Helena didn't get the slides until this morning, but we've got specific goals for each, and some of the opportunities here is really maximising recruitment opportunities. And I mentioned Haringey Works earlier. One tiny example is across, and forgive me for using general practice examples, it's my lived experience, but we've managed to make connections with Haringey Works, and we've had quite a number of staff come through into practices from Haringey Works, and they've been doing a fabulous job encouraging that local recruitment. So recruitment, pathway development, and thinking about how we can work together on careers fairs and joined up comms. The second one, neighbourhood workforce development, that's really about making sure we're using every opportunity to train our staff. We've been doing it for years as well, so it's not completely new, but making sure we're training our staff together, and if we've got one training, we can do that, but also really supporting the no front door approach, no wrong front door, I should say, not no front door, that'd be unfortunate. So ensuring we've got no wrong front door and we're encouraging our staff to deliver in that way. And then the last one is really starting that process of building the comms and making sure we understand where our workforce is at. We also understand what are the challenges, what are the issues, and if we can bring that together, make sure we're communicating across the workforce, it creates real opportunities. And that's my last slide. I will just finish back up on that first one. This is early days and we need to do more and more work on this, but I'm hoping, maybe actually that isn't the best, maybe that's the best, those three areas. I'm hoping those feel like the right sort of places to start, but really happy to take any questions or any thoughts of other areas we should be looking at.
Sorry, Chair, you're on mute.
Thank you. Rookie error. I can see there's a question in the room and a question online, but I just wanted to invoke my chair's privilege and just ask for a couple of things to just be addressed. One, I think it would be good, I know this is early days, so I think it would be good to perhaps have an example of a project when you have one, and to kind of show us how these things kind of map in practice and what that looks like, make it real, I suppose, on the ground. There's a lot of, I mean, I think that we recognise those three kind of chosen areas. I suppose I had a question around that challenge around the NHS and NHS Health and the local authority, and how we're, because I guess at some junctures we might feel like we're competing for staff, and obviously the paying conditions differ, so that creates a challenge, and we see movement between, and that movement between can be really good, I think, in a collaborative sense, really good for both sides of the system. I suppose there's also the voluntary sector or different sides, but just to wonder if we have any reflections in this process around that, and what that might mean and those challenges. Shall we take the other two questions, and then that gives you a bit of time to reflect. So in the room, do you want to introduce yourself to everyone?
Yeah, thank you, Chair. My name is John Porter. I'm a service user, tenant and a skilled trade living in Haringey. To the person published the thing, Cassie Williams, I believe your name is. My two areas of concern are, one, the central referral system, two, the waiting times, and three, the waiting times being delayed due to lack of staff, lack of resources, and lack of skilled individuals in those professional fields. How are you going to be doing and implementing those waiting times to be lowered to a waiting time people expect and not what the outcomes are?
Thanks, John. So if I just take that in the context of this item, so we're looking at workforce. So I think, am I clear? You're asking how will all the work that we're doing in recruitment impact waiting times for residents and the outcomes that they're having? Is that a summary?
No, it's the starting out at central referrals. Central referrals trying to get the appointment with the correct individuals, and then the correct individuals having that appointment in an allocated time. So far, the central referrals waiting time to get skilled individuals to do that appointment system is heavily delayed.
Okay, I see.
Thank you.
Okay.
Thank you, Chair. Thank you, Cassie Williams. Thank
you. And I think it's important just that we also know, obviously Cassie's here representing the whole of the integrated care system. So it's the whole systems document, I think I want to just emphasise, rather than Cassie's. I don't want you to fall under the weight of that heavy burden. It's everybody's responsibility, and it's a collaborative piece of work. I think that's fair, isn't it? I'll take Zena's question, and then if you could answer those three, that would be great. Zena.
Yeah, thanks for this. It's really interesting. Can you hear me? It's really about, hubs, and neighbourhood work appears to be coming back into fashion, having probably gone out of fashion and now returned. So what my question really is some examples, please, of what's going on at neighbourhood level, in real practice, and also how we can connect this up with some of the work which has just started in the council around developing local hubs. Like we've got the family hub at the Triangle, and there's conversations about other types of integrated working. So I would hate for this to be parallel. So I'd like to know what's going on. I think, myself, I don't know about you, Lucia, but, a bit remote from it, really. But if we're going to steer it, I'd like to know what's going on and how we can maximise collaboration. Thank you.
Thanks, Zena. I think those are good questions. You know what? I think we could probably do with an item like this on this topic at people boards, Zena, and that would make sure that you don't feel remote. So I think that's really important that you don't, especially with the family hubs. I guess I'd just reflect and say I feel cited that this work is really closely related to our locality work and the adult social care side. But there's just something there about making sure that when we bring that in for everyone, and that today's opportunity is an opportunity for that. So, Cassie, do you want to?
Absolutely, and I might not answer them quite in the right sequence, and I will bring in Nadine on the question about the central referral service, because I think that might be a Whittington service specifically that you're referring to. But in terms of the integrated working, absolutely, I think the whole point of bringing this here and also to bring it into the borough partnership is to make sure that we're collaborating and thinking. And I would say I am increasingly finding myself in meetings multiple days a week with colleagues from the council and from health and from the voluntary sector, actually, and there really does feel like a sense of collaboration. So it is something that we want to do, and we're trying to think about what are the practical steps that will help everybody. And I think probably you will hear more of that. Examples of hub working. So I think there's, and I'm probably not the best person to describe some of these things, and I don't know, Rachel, whether that's something you might want to describe in a couple of minutes. But stuff like the work going on at the Northumberland Resource Centre, there's amazing collaborative work happening at a hub level, but we've also got lots of integrated services that are happening at a neighbourhoods level, whether that's some of the work that we're doing around frailty and multi-agency teams that have our mental health trust, but also have the Whittington, they have general practice, they've got social worker and the voluntary sector all working together to try and support people with frailty. So it's this sort of work. I mean, actually that happens across NCL, but that's it is not across NCL, across Haringey. It's the sort of thing where we're trying to do this integrated working that will increasingly come towards a locality level. The sort of examples, and I think again it would be great to bring back other examples in future, but one thing that they've already started to talk about in terms of neighbourhood training is they've already started, particularly in the East locality, to provide multi-agency training around various things. So they've already done one on rough sleeping. They've done one around the CAM service and another around GAM care, which is gambling awareness and how you support people who have gambling difficulties. So there's those sorts of examples, and sharing that training together are the sorts of things that have started to be happening. And then the competition versus collaboration is a really interesting one. Of course, you are right that there is some competition. I personally, and other colleagues would have to comment on it, and perhaps something we need to take away, I don't feel a lot of competition across the system for staff. I mean, obviously we know people move around and we know people progress, but I certainly don't have a sense as we're meeting together that everyone's sort of saying, get off my staff sort of thing. So I think in general, what we're trying to do is create development routes for all our staff. And sometimes if it means they move on from my organisation to another organisation, it's because that's a development opportunity and that's positive, but happy to take it as something to look away. And then I suppose responding to John's question, the only thing I would say is from a workforce perspective, our goal is to make sure that we are getting staff into roles and local staff who want to work in Haringey and who are committed to Haringey residents. And I do believe that that will contribute in the end to supporting filling the teams that need recruitment and to going forward. But I'll hand over to Nadine, if that's okay, Councillor Dasneves, just to speak about the central referral service.
Yeah, I think just before you do, Cassie, just to note as well, because I think within Councillor Brabazon's question, there's something about collaboration as a whole at kind of hub, at locality level, etc. But then there's something a bit more specific about how the workforce piece is being, how we're collaborating on that and how we're integrating that with family hubs, etc. So, and just kind of you make it clear there's those two bits, if that. And
we need to build that in more. So I know that. Yes, absolutely.
Okay, thank you, Nadine, and then Rachel.
Afternoon, everyone. For anybody who doesn't know me, I'm Nadine. I'm the Clinical and Care Director for Haringey for NCL for the ICB, but I also am the Clinical Director for Whittington Health for Community Services, so responsible for the adult community health in Haringey. And I was going to answer with that hat on, although we always wear all of them, just from in terms of a bit of reassurance around your challenge, John. We're doing quite a lot of work in recruitment. We pay for targeted adverts on things like LinkedIn, and we advertise on social media to try and attract people to Haringey specifically. We're developing, where we can't recruit, we're developing new roles. So, for example, we're recruiting community sickle cell nurses specifically to Haringey at the moment. And where we can't recruit them, we're developing training posts so we can train people up from scratch to become specialists in sickle cell care, which is a great skill to have because we can't recruit them. There aren't the specialists out there, especially because all of London is trying to recruit these nurses in particular at the moment. We're trying to expand apprenticeships, but there's loads of work to still be done in that space. For example, I go into some of the Haringey secondary schools and talk about careers in the NHS and how to get onto apprenticeships and what sort of, to try and build our future workforce from Haringey, which I think is really important. I will absolutely acknowledge there's quite a lot of services in community services that have got quite long waits. For example, physiotherapy, so musculoskeletal physiotherapy, if you've got back pain or knee pain, they paused 3 times during COVID and have really struggled to recover. So they're doing some different things at the moment. So one of the things that we just finished with Bridge Renewal Trust partners and local resident groups is redesigning the pain management program for our Turkish speaking communities, and we're going to try that because we recognise they're not getting great outcomes at the moment from what we offer. And then in February, the MSK Physio Service are running 2 community assessment days at Tottenham Green Leisure Centre, and they're inviting nearly 1,000 people off the waiting list to come in and have a much more strengths-based what matters to me conversation. And we've got lots of partners there, from talking therapies, from the team doing the outreach around physical health checks. We've got podiatry there. We've got one new Haringey hopefully there. We've got lots of partners to try and provide earlier support and the recognition that actually in lots of cases it's not just your knee pain that's stopping you, it's a whole wide range of other things. But also to just note there are actually lots of community services at the moment that are delivering within the time frame. So if you've got heart failure or diabetes, you're seen in a really timely way for those services, and they've been doing some specific work around hard to reach residents in East Haringey and the most deprived postcodes to try and improve their health outcomes, and actually they're showing some really good results. That said, for community healthcare, it's certainly not all resolved. I can't talk in detail to some of the work going on in outpatient recovery, so from the specialist services in the hospital. But I know lots of organisations are putting on extra clinics and working weekends to try and catch up. But it is a huge task. And we really appreciate that it feels really hard on the ground when you can't get an appointment in the time frame you want.
Thanks, Nadine. So I kind of feel like, in summary, a lot of work going on. Some of them are quite mini mountains or not so mini mountains to climb. The politician in the room can probably say would be easier with some sort of national strategies that we might like that we don't necessarily have in place. One thing I wanted to pick up that you mentioned going into schools, which I think is brilliant. Really glad to hear that. Wonder if we councillors might like to hear about which schools and just hear a little bit about that work, because we might also, through our work in our wards, be able to promote that as well. Although you may feel you're pretty stretched in that resource, but it would be good to hear a little bit about, perhaps we could do an email to all councillors just talking about where you've been and we can identify where there might be. Certainly in my experience, sometimes with services, some schools fall through and what have you, or don't know they can ask, and I know I do go regularly into schools in my ward, especially secondaries, talk about all sorts of things, and they have career sessions. So good to know that that's available as an offer. So I wonder if we could pick that up. Rachel.
Thank you. I wondered if I might just come back on Councillor Brabazon's point about neighbourhood working, and should that be an orienting consideration for our workforce plans, to which the answer is completely yes. But I just wanted to kind of outline where I think we are at the moment, not comprehensively, but just very, very briefly in relation to neighbourhood working, and to suggest that it is going to be a focus of the next borough partnership exec, and so it might be timely to then bring an update to the next health and wellbeing board. It would be really helpful, I think, to get people's views and sort of make sure that we're all on the same page with it. We've talked in the past, and I think we are all completely signed up to services being much more visible and readily accessible to residents in their communities, the place that they walk every day. We need to understand the assets and what happens in a neighbourhood, and those assets, which are generally VCS organisations and teams and community buildings, need to be conscious of each other. Connections between professionals who work in an area, making best use of the opportunities that we have for co-location, and just taking that much more kind of preventative early identification approach across all of our agencies. So that has been our orienting force around our neighbourhood working, which is at 100% sort of the locality working that's happening in the council. Where we've got to in terms of workforce is, you know, John, I'm sure would speak to this much more eloquently than I could. Huge amount of work, I think, done in adult social care around taking a locality-based approach, and through community health teams, again, trying to really build on our central, east and west locality teams, so therapists being built into the teams of district nurses and others who are already community facing. And I know I see sort of Gary and Natalie in the room, and again, it was fantastic when we were at BEH to speak to some of the core teams. So the mental health services also organised on that central, east and west basis. We have done a lot of work, and I'll talk a little bit to some of it in the borough partnership update. So I won't speak to it now, but just around initiatives that build on that multi-agency working on the areas that are identified by professionals as being particularly important to them, and many of those are around seeking quick input on mental health presentations amongst professionals. So we've got a lot of initiatives. We've been doing some really interesting work around web-based tools that make it visible for different teams who's working in a locality. So that is really interesting and speaks exactly to our priorities. There's a huge amount of work that's going on around Northumberland Park, around Hornsey Health Centre, and of course around the Integrated Health Hub at Wood Green, and opportunities to sort of maximise the interaction that happens through co-location. But I would say that we're still, in terms of making the connections between primary care and the different health, mental health services that work in a place, we have got to get to our recruitment position is really, really stretched across all of those services and all of those teams, and my sense is that that has to be the focus and orientation. That's why I'm really pleased that the workforce strategy is really focusing on that entry level recruitment, because there's a huge amount of energy going into just recruitment into adult social care, into community mental health. And when we get to a position, I think it's very top of everybody's agenda to really think about how do we bring teams together? How do we really make that sort of multi-agency working happen in practice? We're just going to have to phase it in line with the recruitment challenges that we're facing. Thank you.
Thank you. That's very helpful, Rachel. We will come back to these. I mean, we do regularly, don't we? And we will continuously, especially since it is the modus operandi, it is the way to go forward, working together, isn't it? I'd like to suggest a time that we might come back with some sort of example projects of workforce and how it's worked, what we've learned, what was good, and the good, the bad, and the ugly, for a future health and wellbeing board. When could that work? In 5 months time, 6 months time?
That seems sensible to me. I think give it some time to develop and have some really strong examples. So I'd go for 6 months, but sort of just rounding it up.
I just wanted to mention that our workforce lead has has been on paternity leave. So I think if we said 5 to 6 months, that sounds reasonable, but just because I think he's back towards the end of February, is that right? Yeah,
That's right. Yeah.
Okay, so maybe 6 months' time. John, I can see you've got your hand up, but I'm going to have to move us from this item on fairly swiftly. So if it's a really quick thing, we can take it. But do you want to move on because we've got quite a lot on the agenda?
This is directed at the NHS individuals. Is it possible short term to centralise district nurse and community treatment to a central area whereby staff and resources are a lot better put and not in stretched areas? Thank you. Thank you, Chair.
John, can I suggest that we pick up that as because it's coming out strongly from your feedback as a theme, and we might not have all the people in the room who want to, and they might not be prepared. Could I suggest perhaps at the next Health and Wellbeing Board we have that as a bit of a topic and we discuss that? I don't know how those on the call feel, because I don't know that they'll be able to answer that question in it and do it any justice right now. But we could have a more full discussion on how to challenge some of those tackle some of those challenges. Forgive me. Does that seem reasonable to everyone? I can see some nodding heads. Is that okay? And then we can give it a bit more the attention it deserves, I think, John, if that's okay with you. Yes, no?
Oh, sorry, yeah, yes, no problem.
Okay, all right,
Yeah,
thank you. Okay, so apologies everyone, I'm going to move us on to the next item. Thank you for that, and I look forward to hearing about some innovative and collaborative projects at a future one. So we're going to skip item 9 as per the agenda and move on to the next item, which is the Start Well consultation. And I think, Rachel, you're just going to take us through that. Hopefully quite a few people will be very aware of this now, but do take us through.
So this was just to make people aware that the Start Well consultation has been launched. I think there have been separate discussions in many different fora on this, so I wasn't going to dwell on it. I wanted it to be noted for the purposes of the minutes that that it was launched, and my understanding is that there will be specifically a Haringey Council response, which I think would be welcome. The item also came to the GP collaborative that Nadine chairs and hosts, so primary care was able to provide feedback really directly, and I'm open to whether we want to have a Health and Wellbeing Board borough response, but just to note that that we have already been very actively involved in and engaged in providing feedback to Start Well consultation.
Thanks, Rachel. Yes, so I think there will be a collaborative submission from the council, as you suggest. No doubt, with me as chair of Health and Wellbeing Board and others, excuse me, you will also be aware, and those who might watch this recording later or in a future date might want to be aware, that we that both councillors and the local MP have written a response, and particularly, obviously we're very concerned to see any services closed, but in particular in support of Whittington Maternity. You'll all be aware of that. I think that if I was to lay a marker, one of my largest concerns is around equity and issues, and we know that part of Start Well, and part of the strategy and work that's taking place hopes to address this, but I cannot emphasise enough the differences between outcomes for women from minoritized, black and minoritized communities is of serious concern, and the differences for their children. So I think that's a primary concern that comes out to me when I am around and out in the borough, and so I feel it's really important to cite that here. I know it's on the agenda and the menu, but just felt like I wanted to make a few observations. Nadine, did you want to come in?
Yeah, I was going to say we brought the Startwell consultation team to the GP collaborative, as Rachel said, and one of the things we all, I guess, challenged them on from a Haringey perspective is to make sure all of those voices that are not often heard were heard in this process, and they've done an equalities piece of work to ensure that they are engaging grassroots residents groups to ensure that their feedback is felt and heard loudly in this process.
I thank you very much. I think that's very important, and I know when I think about some of the work the public health team have done, reaching people that we don't usually reach, we've made some progress and efforts within our own work within the council. So I think there's lots of learning and work to share there, and we have plenty of really good organisations, as I think you know better than anyone, Nadine, in the borough who can help do that. But I just wanted to emphasise that that's a significant concern is access to services and and then layered on top of that the outcomes that women see, especially women from minoritised communities. Jonathan, did you want to come in?
Really, just to echo that, I've just put in the chat a link to where people can get involved and fill in the forms and so on. And I guess it's important to note that the preferred option is maintaining Whittington services, but that doesn't mean that we should let that go as, oh well, it'll be all right then. Really, we do need everybody to participate in this consultation, because the more people that respond to the consultation, the better.
Yes, I think that's really good. And Bosra, when you do the minutes, if you can make sure you include the link that Jonathan's sharing, so that it's in there for people should they review it. Many of you might have seen that David Lammy did a little video, and he was born in the Whittington, so everybody's got skin in the game, so to speak, in this one. But I think further on there'll be more. There are conversations to have also about there's something about having the right services and making sure we don't see closures, but then it's also about them running well and serving and delivering the outcomes that women and our babies need so badly. Rachel.
So I just wanted to come back to the point about responses, and noting that there's been a response from councillors to ask, we don't need to resolve it in this meeting, but just to pose the question of whether we want a response from the Health and Wellbeing Board that is a Haringey Health and Wellbeing response based around likely to sort of use as its basis the council response, but with added weight because it's a partnership board. So open to ideas about that, and happy to kind of take feedback offline if that's easiest.
Yeah, let's have that conversation, Rachel, about how we do the different responses, the different levels, and what's the most appropriate. Absolutely, thank you. Well, thanks very much, everyone. And if everyone's happy, I'm going to move us on to our next item. Will, you're going to take us through the health and wellbeing strategy development.
Yes. Hi, everyone. I'm Will Maris. I'm Director of Public Health. I think you all know me. I'm just going to give a very brief verbal update on the development of the new Haringey Health and Wellbeing Strategy, which is the strategy that will be key strategy that will be owned by this board for delivery over the next 4 to 5 years. We've talked before about the process of developing the strategy, and that's very much in line with our principles of working with our communities and co-design, and also with the sort of Haringey deal, which is the way of reaching people and engaging them in the discussion. So in the autumn, we had a number of different channels for engaging with communities, a large event with different groups, some much smaller focused engagement sessions where my team were out in libraries, they went out to different community groups, they did sort of just open sessions where people could come up and give feedback. They went to speak to parents and families as well. We also put the questions that we were asking up on our website as well, and had some online responses as well. And we also brought in previous engagement that have been done, some really excellent work, for example, through Healthwatch and Bridge, partners on the Health and Wellbeing Board, that been done previously. So I'm just going to talk about the themes that have come out of the engagement that we want to take forward as part of the strategy. But firstly, I would want to talk about the principles of the way that we work as well. Again, this is through the engagement work that we did, but also through the work that we've been doing previously through the board. So I think that principle of co-production and engagement with communities is embedded in all the work that we do. So in the themes, both developing the themes, but then in the work to deliver the themes, we generally have a co-production approach in place in all of those areas, and we can strengthen that as we develop the strategy. Another key overarching principle is about equity of outcomes for our different communities, and explicitly challenging discrimination and racism in the work that we do, and recognizing that we have work to do in that area. We've talked about partnership working already, and that is a strong principle that will underlie the strategy, probably goes without saying. And then something around getting the basics right in terms of quality and accessibility of our services. And I think that was highlighted by John's questions earlier, just how do we ensure that for our residents, services are easy to access and are of a high quality across the range of health and social care services. So they're the overarching principles, but the themes that came out strongly from the engagement, and I don't think many of these will be a surprise. So the first theme is around mental health and well-being for all ages. And that includes both the focus on services that we're making through the Borough Partnership, and Rachel may allude to later, and that focus on prevention in those services, but also how we tackle social isolation as well. And this links to work, for example, that we're doing through the culture strategy in Haringey and through our leisure and well-being approach, because what came out strongly is people want to be involved in activities in their community that improve well-being, like getting more physically active, taking part of those clubs. Culture is great as well for mental health and well-being. So that's the first theme. The second theme is about housing and health. And three things came out strongly in this, or two broad areas. So firstly is around the quality of the existing housing stock in Haringey. And we'll be well aware of those issues around things like damp and mold, and just the basics of getting kind of repairs done in both the social housing sector and the private rented sector. But also looking forward, how to ensure in a housing crisis, in a national housing crisis, where we are developing new homes, we are catering for people with specific needs in the borough. So that's theme 2. Theme 3 is around placemaking and the physical environment. So we had feedback around things like air quality and wanting to breathe clean air, which we are actually making progress in Haringey and London, access to affordable, healthy food, green spaces and parks, and how we can use the levers we have to make healthier high streets, including looking at issues such as gambling and hot food takeaways, which are very challenging areas. The final theme, and this really links to the first discussion and the work of the Borough Partnership, is around preventative health and care for all. So how do we work together to ensure that our communities have access to good quality preventative health and care in the neighbourhoods where they live? And how do we make measurable improvements in equity in some of the key outcomes that we've talked about, like stillbirth rates, immunisations, access to speech and language, and heart attacks, and preventing heart attacks and strokes. So the 4 areas to recap: mental health and wellbeing, housing, healthy and safe placemaking, and how we improve our health and care system to make it more preventative and more equitable. So the next stages for this are to put those themes into the draft document that will come to either the next board or the one after. So I'm working with colleagues across the partnership over the next 6 weeks, 6 to 8 weeks, so we can flesh out some really key deliverables, some key actions against those themes. There is a lot of work going on already, and we already have co-designing a lot of that work across those streams, and just being clear about delivery and governance for those areas. So that's my update for today, and we'll bring back either the next board in March or the subsequent one, the draft strategy for us all to look at and go through with some specific actions and outcomes and measurables for the next period. Thank you.
Thanks, Will. I mean, that's really useful, really interesting. And as you say, there are no huge surprises there. I just have a bit of a reflection as the chair, which is just that all four of those areas really require that really good collaboration, either within different parts of the council or across the partnership and the system. And we know we do very good collaborative work, but we also know that things fall down at that in that space as well, because it's harder, and we have different cultures and we have different priorities, etc. So for me, there's something about, and I think that's what you're saying, the next stage is about really about those deliverables, but also about the governance and structure, how we increase the ownership of that strategy, how we naturalise it to be part of the language, to be part of, and many of those elements echo what we see in the Haringey deal within the council and some of the priorities set out for the partnership, don't they? But it's just about making everyone challenges. When you have one person responsible, it's easier, isn't it, to hold to account that particular team, and when things are more dissipated, we can do better work together. But it's that governance and accountability and how we're going to feed back and how we're going to tell residents, you said, and these are the things we did. And you're right, there's lots of work already going on, which I think is really heartening. But it's a relief that we're on the right lines. But I do think that there's something about how we implement both within the council and without. I think it needs more. I'm sure these are things you're thinking about all the time. And I also know, to your credit, you're doing a lot of work where you're spending time with other teams, for example, within the council, to talk to them about some of the health priorities and how they connect. So I think you're doing a lot of that joined up work. But there's definitely something there for me around the governance and the implementation, and also about what we can achieve. And I thought it was really powerful that you said people want to be involved in their community, in activities in their community that can help their well-being. And I think that's good, because we're often sort of talking about behaviour change and nudging people, etc. And actually, people do want to be able to access those things. It's just not always easy, and we're all human beings, so we all know that. So there's just something about how we do it well, and so that it delivers what people need and want, and ultimately makes them feel better, healthier, and live longer, hopefully. So there's lots of hands. Zena was first, so I'm going to take Zena, then Beverly, and then I'll take you, John.
Yeah, I thought that was a really interesting summary and very succinct and helpful. I just want to say a couple of things. First of all, about housing. I don't think anybody could disagree with the priority of housing, and that underpins health and well-being in so many different ways. And I'd like to make sure that we're all sort of, I hate to say the word joined up, but we're all aware of some of the issues around housing allocations and things like that. We have to be in a position where we control the levers of who gets what, because it's rationed. There isn't anywhere around that. There's more need than there is the housing. So we can't be like woolly and fluffy about this. We really have to look, in my view, and Lucia and I sit on the people board, and we're trying to push for this review of housing allocations. And in my view, we need to be much stronger in controlling the levers of how housing is allocated around need and so on, not necessarily about, choice-based this and who's been on the list the longest. We really have to have a good review of this if we're going to meet need more effectively. We don't really do anybody any favours if we don't do that. Apart from building up a lot of problems in the local authority, if we aren't, for example, housing families where there are multiple health needs, or where I'm going to say, so where there are 3 autistic children and stuff like that, so I think that's really important. And also, equity doesn't mean the same. In our borough, we have to have differential look from west to east. We can't do it, in my view, any other way, because of the disparities of wealth and every disparity we know about on every indicator everywhere. So we have to do that. And so I think, you know, getting the basics right means having some hard decisions about how we distribute what we have and where we work. So other than that, I mean, those are my views anyway. But I think it's really a very interesting list. I was really pleased to hear the breadth of it. That's a good starting point.
Thanks, Zena. Easy peasy, isn't it?
Absolutely, a doddle.
Exactly. But in all seriousness, thank you, and I think you're right. And that, you know, Beverly and I talk about equity a lot, and I think that that's the key, isn't it? How we use our resources. Definitely do come in.
So thanks very much, and thanks very much, Will, to you and your team. I just want to echo Councillor Brabazon's feedback around the you know, really breadth and succinctness of the you know, how we will progress going forward. I suppose I just wanted to introduce here, and you'll be aware of it, Will, because you were at the meeting with me yesterday, and we're at the ICP. We had a conversation about measurement of outcomes and how will we measure how well we're doing, and that theme of equity, I think, was a really strong theme in terms of how are we, you know, in terms of measuring outcomes. Are we talking about closing the gap, as it were, between the differential groups in terms of outcomes? Are we talking about raising everybody up? I think that was a point that you made, and I think it'd be useful just to explore in the ongoing conversations how we're actually going to measure outcomes in terms of the strategy. And I think it's very useful to have that golden thread through to that ICP level sort of outcomes that we had yesterday. So thanks very much again. Yeah.
Thanks, Beverly, and you're right, because we only what counts is what we measure. So absolutely. John, you want to come in?
Yeah, thank you, Chair. Will, 3 points I'm bringing up. One, on accessibility. If you need assistance, I'm free of charge. I can assist you on that point on all areas, sight, sound and mobility. I have people on my forums I can assist you with. Second point, where we do have people on the screen I can see, mental health and counselling. Tonight, due to another area, I'm sleeping in a hotel due to repairs and my dwelling being 9 degrees due to no heating. Day 3 in a hotel. I am highlighting the NHS cannot cope. I have a social worker, I have a therapist. I had them in place. But the bottom line is the repairs service are letting people down and overcrowding the system whereby people cannot cope. In regards to other areas, right, I'm prepared to assist where there's failings. But where you're saying stuff in the community, I just would like to know an overall figurehead and decision maker whereby when you want people to be in the community and have activities, we had a project which was meant to be 10 to 15 days, now 5 months long, no decision maker to get over the finish line other than myself and other industry skilled trades to get that project done. If there's an overhaul figurehead and decision maker, the communities can have activities that are deemed safe and deemed accessible for everyone, not just able-bodied individuals. Thank you, Chair, and Will, the offer's there if you wish to accept it. Thank you.
Thanks, John. There's a good offer there, so thank you for that. I think it's sobering to hear about your housing circumstances, and I think it's a reminder, and I think many of us don't need reminding because my inbox and the people I see in my surgeries tell me similar stories. So it is very challenging at the moment. So I agree, and I know that the council, there is a lot of work to do, and it is somewhat, I think the leader's been really open, it's somewhat of a mountain to climb. But we have also lots of challenges in the private rented sector too, and beyond that actually. On your specific project, I think, John, if you want to write to me about the project, and then I can pick up with whoever it is, and I can pick it up the case, I'm not aware of it, but let's do that outside of this meeting if that's okay. Just because you know, I think we don't have time here now to go over the detail of that, and I'm not sure the right person will be here in the space. But if you could write directly to me, just with the info and details, and we can pick that up if that's okay.
Yeah, no problem.
Thank you. Thank you for sharing your experiences. And likewise, if I'm sure you are in touch with your ward councillors about your specific case, but likely I can direct you in the right place if you don't feel you've had the right input yet on the housing there as well. But thank you. And thanks, Will, and thanks to the team. And I think we just look forward to that document coming forward and to a bit more work, a bit more info, and at a future meeting. So look forward to that. Thank you. Now, I think we're now going to, Paul has now joined us. And so, Paul, I think you're going to take us through the, which are you going to do first? What are we going to do first? The Better Care Fund, or, and then we've got the whole piece on the borough. Is Paul with us?
So
yes.
Yes, I am. Yes. So I'm frantically trying to get my PowerPoint to work. So apologies, everybody. Yeah, I'm just going to talk about the Better Care Fund plan, if that's okay with John Tomlinson as well. So is it okay if I put some slides up just to go through that? Because I've got some slides to accompany the report. Is that okay with everybody?
Yes.
Can you hear me? Yeah. Sorry, I couldn't
Yes,
see whether you'd frozen there
Yeah.
or not. Yeah. Can people see it yet, or is it still loading?
We can see it, but it's not on the full slideshow for us, so it's a bit small.
Right. Okay. Oh, well, that's interesting because it's not telling me that I can. Is that better?
Yes.
Yeah.
Great. Okay. So hopefully, John and I can kind of do a quick run through of the kind of slides. And sorry, this is my slightly earlier version of the slides because my kind of final one seems to have been. Something's happened to it, so it's probably not quite perfect, but apologies. So obviously this is a company's report. There's a report which I'm going to kind of very quickly walk through and give some highlights around it. So for those of you who are used to receiving the Better Care Fund plan, it's obviously an annual cycle. This particular one that we're going to talk about today is for 23-25, but there is that's 2 years, but there is also a break to try to update the slides for 24-25 as well, which we haven't got any further details about the update. So I'm not going to really talk about that for 24-25, but we know that there is an opportunity to update it later. So this report should have gone to the kind of council meeting really with last year. So it's a bit late, and it just describes the sign off of the 23-24 Better Care Fund plan. And includes the narrative in the report, and also an investment schedule and a rather complex spreadsheet, which we've tried to kind of print out for the board as well. And that contains our investment schedule, in other words, where how much money is going where, and also the metrics that we have to deliver on as well. There's also something complicated in it around demand and capacity, and an analysis that we have to do, every borough has to do, which is about our intermediate care services. So those are the services that help people recover once they've had a crisis, whether that crisis has led them to hospital or whether they're in their own homes. Intermediate care services is a global term to describe services that help people recover. So the Health and Wellbeing Board has to sign off the plan that we've submitted, and because many areas, not just Haringey, have kind of some of the Health and Wellbeing boards don't necessarily meet in times like August, that there is an opportunity which we've taken to kind of have chairs sign off of the kind of the accompanying report as well. So I'm going to move us on and just say that the background of this is what is the Better Care Fund plan? It's about a programme to support integration of health and social care and to promote independence of residents. And I'm going to come on to some of the details and the requirements within in a second. But basically this information today has come to the board to provide assurance that we're maintaining a commitment to health and social care integration. So the there are some kind of strings attached to the Better Care Fund plans nationally, which we have to follow locally. So one of them is it has to come to the Health and Wellbeing Board, and we had to submit a narrative in Excel spreadsheet. But actually, there's a policy framework. That policy framework talks about also the distribution of money, which I'll come on to in a second. But actually, the two key Better Care Fund plan policy objectives are to enable people to stay safe, well, and independent at home for longer, and also to provide the right care in the right place at the right time. Now, those particular objectives have been in place for about 5 years now, so we should be used to kind of working through them. How we do that is the kind of, the submission in the narrative, which explains a kind of, I'm going to come on to this in a minute, like a tiered approach to the support that's available depending on people's needs. But actually, it also talks as part of the policy framework around the importance of investing in out of hospital services, and also making a contribution to social care, which is always maintained in line with an uplift to the NHS, which was running at kind of 5.7% last year. So just to cut to the turkey around what it means specifically for Haringey, and this is the table here is the investment schedule. So there are 1 or 2 questions about 24-25. I'm just going to come on to that at the end about some further work the councils and ICB need to do about the investment schedule. But for 23-24, there's £38 million invested in the Better Care Fund plan. So it's a fair chunk of funding. Of that funding, around 23.5 million comes from what's called the minimum NHS contribution, essentially from the ICB. And of that, according to the rules, 7.7 million of that needs to be invested in 23-24 on what's described as being adult social care related spend, but actually could include things like prevention as well, and housing kind of investments. The Better Care Fund plan itself is for adults 18 plus. Largely, there aren't many areas contributing anything into children's services because of the kind of the rules around the Better Care Fund plan. So it's predominantly for adults. 6.7 million needs to be invested in out of hospital spend. We spend far more than that within kind of Haringey, but that is the kind of the minimum requirement around it. There are also additional spends alongside the 23.5 million in improved Better Care Fund plan investment, which goes directly to the council, and also its disabled facilities grant again goes directly to the council as well. For the first time in 23-24, there was an additional investment in something called the discharge fund, which is to kind of recognise that there's some additional requirements and funding that's needed for both the NHS and council. And it was up to a combination of the council to decide locally where that funding was spent on, as long as it was spent on kind of out of hospital services, and also an ICB contribution across the 5 boroughs, which was then divided up into kind of the 5 boroughs in a way that councils and ICB agreed. So the total amount of money that went into from the discharge fund into Haringey was 2.4 million in total. That figure rises up to 4.3 million in 24-25. So we think that's been kind of taken from kind of future NHS discharge NHS investments, which is why in the operating plan for this year coming up for 24-25, it's a relatively modest increase in the uplifts. As I say, there is a requirement every year to invest in an increased slice of that money in terms of absolute figures in adult social care, and the increase was 412k uplift in adult social care spend from the minimum NHS contribution for 23-24, and I'll come on to what that's been invested in later with John. Okay, so just before we kind of go into the details of the funding, which are actually in the appendix of the report in a lot of detail, and I've highlighted the new schemes around it. Just the structure of the narrative we've been using is quite helpful to understand that. So we've identified essentially that we've got a tiered approach to investment, which is kind of followed through the kind of the Better Care Fund plan. And we start out talking about healthy, safe and well. So that's kind of messages around public health for the general population. What I would say is largely the Better Care Fund plan doesn't focus on that element, but focuses on the tiers above it. So the next tier above that are people who maybe need some early intervention and prevention, are beginning to kind of slow down or maybe struggle a little bit. And so there is some investment in that space. Around 5% of the funding goes to that particular kind of tier. We've then got a large amounts of funding in kind of care and support. So these are in services and solutions which relate to people with more complex needs, for example. People who might need some support through either kind of community health or complex care teams, also in adult social care as well. And then the final element is, it's called specialist and emergency, but really it's the out of hospital kind of services to support intermediate care to get people back up on their feet as well. So that overall care cone model has existed for several years. It's for all the population, but actually it's a really useful springboard to describe our investments, and that's how we've done it in the narrative, just to order kind of the description of the investments. We were also invited to kind of identify a number of challenges within our system. I don't think any of these things on the right hand side there are any surprise whatsoever. So we're talking about managing. We've talked about the legacy of the pandemic, but really it's a set of system shocks, which include things like cost of living as well, which have actually impacted on people, the number of people whose underlying health has worsened. And we think there's been an increase of about 15 to 20% in the number of people who are, say, over 50 who have got moderate or severe frailty, just as an example of that. So it might sound counterintuitive, but of the 5 boroughs, for example, Haringey has got the greatest number of people who are frail, greater than Barnet in absolute terms, because frailty is often a combination of obviously age and acquiring health conditions, but also about deprivation as well. The second element is the kind of ensuring our out of hospital systems are well prepared for increased activity in NHS trusts. It's clearly an important one for today, isn't it, given how cold it is, and also to address underlying issues associated with equity of access, outcomes and experience. And again, these are things that I think the kind of the Health and Wellbeing Board has been talking about as well. So just very briefly, I'm going to come on to some of our achievements. These have been done jointly. So we've got things that we're really proud of in terms of helping people with early health prevention. So things like, distributing the Aging Well guide, and which, there's a link there for people to kind of to look at that if you're unfamiliar with it. But it's basically some simple messages to allow people to kind of stay fit and well and independent as possible. So that's really popular, particularly within hospitals, for example, at the minute. And we've asked for another print run of that, which is really great to hear that it's been very popular with a number of organisations in terms of helping people return home, but also to kind of manage their well-being and health. We've also got we're developing a kind of awareness raising and training to improve the knowledge of professionals and volunteers and work with older people. Sometimes that's simple messages, sometimes it's a bit more complicated, depending on whether people want to be kind of essentially age well friends or age well champions as part of a move towards age-friendly Haringey. I just think it's fair to say as well, we've also seen a significant increase in the number of GP consultations for older people pre-pandemic to where we are now, and that's been sustained into 2023. And the thing that we're really, I suppose, mindful of is that the number of consultations is particularly high, particularly amongst our more deprived areas as well, which you might see is a bad thing, but actually it's quite a good thing that people are actually reaching out to our GPs. But we know there's a lot more we can do in that space. We've had a really positive evaluation of what's called our multi-agency care and coordination team, a multidisciplinary team that supports people with proactive care. So in other words, people who've got complex needs and need a multidisciplinary approach to that. So they see nearly 2,000 individuals, and some of the outcomes in that space have been really powerful, not just in terms of satisfaction, but also outcomes for the individuals and also outcomes for the system. And there's 40% reduction, say, in emergency admissions post-intervention in that space. We've continued to invest quite heavily in our, out of hospital services. And that's a real multi-agency approach where we work together. 93% of Haringey patients are discharged home from hospital during 22-23, and that figure's actually improved still further. So at the heart of it is the idea that people want to get home as soon as they can when they're fit and well, and we need to enable that as well. So we're always mindful of that. The thing we need to improve is the timeliness of those discharges, which is a kind of a key issue for all of us. We've seen nearly 1,350 reablement episodes to help predominantly older people recover to undertake daily living tasks. And there's been some really positive improvements from the previous year, the number of people discharged to reablement who stayed at home 91 days later. And we've also seen a significant increase, which we've supported through the Better Care Fund plan, in the number of people who are seen by the Rapid Response Service as an alternative to go to A&E. So all of those things have helped kind of reduce emergency admissions by nearly a third between 2019-20 and 22-23. That's really great news in terms of trying to kind of make sure people are safe and well, we avoid crises. It also means that, of course, the people that are in the hospital now truly need to be there, and we've seen a greater level of multimorbidity and acuity in the population as a whole but also in hospital as well. So we have invested, what we invested in 23-24. John, I don't know whether you want to go through the council investments, and then I can kind of talk through the NHS investments, or do you want me to continue to steer on? It's up to you.
You carry on, Paul, and I'll chip in at the end with some of the most important investments around carers, etc.
Yes, of course. Yes, you were a
John,
little bit faint there.
I think
I
your
got the
mic's in the
message.
wrong place,
Yeah.
John. Can't hear you, John.
You're a little bit faint.
No, I heard what you were saying, John. So I'll leave John to talk about the carers investment, which I think is
apologies. I've just pulled my
yeah.
Okay.
I'm glad to see I'm not the only person who does that, John. So, yeah, we've kind of continued to invest in early health and prevention in our neighbourhood model. Carers Support Network will no doubt support that. I'll let John talk about that in a minute. We've also really important thing, I think, it's a very small thing really, but it was really important for a lot of people. We've tried to invest in bereavement services for carers of people with terminal conditions on end-of-life pathways, and also supported a few voluntary sector schemes which also look at bereavement around traumatic events as well. And we're really pleased with being able to put an investment in for this year. We've also included an expansion of our community health services to support with people with medium to long-term care needs, and also supported our Whittington Health colleagues, for example, in moving towards things like self-referral for people, which has been well received by the patients, but also the health community as well. And it's great that they're doing some further work to promote some of the thinking around how do we manage wait lists, because there is a wait list there. We've also kind of brought into the fold within the Better Care Fund plan the ICB's wheelchair services and NHS service, to bring that alongside to the investment we're putting into equipment as well in 23-24. And we've continued to invest quite substantially, including through the discharge fund, in a range of different kind of intermediate care services, and also support for a growing number of people who are living in challenging housing environments, and maybe who are also homeless as well, and some people, but challenging housing environments. Maybe they've got somewhere to go back to, but they're living in all sorts of conditions. And I'm sure you just talked about that in one of the previous items. So, John, did you want to say something about the carers support network at this point?
Yeah, that'd be really good. Just to bring the board up to speed, I mean, we've done quite a lot of work with our carers groups in those localities that were mentioned earlier. And we've kind of brought groups together to actually properly co-produce the kinds of services that our carers are telling us they need. And that will be kind of reflected as we start to review and update our carer strategy. Now, what we've kind of found is that, I mean, as you'd expect, carers really want to get the basics right. And that's things like information, communication, carers' well-being, respite, which is always a key issue, and carers' concessions and opportunities. In those kind of workshops, I mean, they did raise a number of things that are really working well. And I think it's incumbent on us to ensure that we build on those things. And some of the things that they flagged up were things like carers groups, specific groups, particularly coffee mornings, Carer First, carer forums, and also they kind of touched on some of the support areas and mechanisms that in Haringey work well, including Disability Action Haringey, Haringey circle and support from friends and carers. So sorry, support from friends and relatives and local communities are really important, and that I think really works well into the localities approach. I think the strength-based approach in adult social care, working across with other professionals, will really work well. So overall, we're looking at investing an extra 400,000 in carer services. So it's a real push to make sure that our very precious resource of carers are well supported and able to go forward and kind of be well and look after their relatives. Okay, Paul.
Thanks, John. Yeah, just to add one sentence to that, John, which is obviously carers are everybody's responsibility. So it shouldn't rest on the council's kind of remit alone. It's definitely a shared agenda between the NHS and councils as well. I just wanted to say just a final kind of observation around the 24-25 refresh. We don't know the details of that yet. What we do know, though, is that actually we haven't quite aligned up our kind of utilisation of the discharge fund between all 5 NCL councils and the ICB. So there's conversations are happening this quarter on that basis. Again, North Central London is not alone in those kind of spaces, because there's obviously we're all aware of the kind of the increasing kind of pressures there are on kind of the public sector purse. So it's no surprise that we haven't kind of finished the deal in that space for something that was originally, at the time we kind of constructed it, you know, a little bit down the road. We kind of spent a bit of time focusing on 23-24 and trying to resolve some of those issues. So that's the end of the kind of the presentation. So I'll just take off my slide so I can kind of see what people are saying there. So I don't know whether there's any kind of questions for John or I or colleagues.
Thanks, Paul. That's very helpful. A lot of detail there. I've seen John and I've seen Beverly, but I'm just going to ask a few questions first, if that's okay. I know I don't usually do it that way. I had a couple of very specific questions, which might be ones to be fed back after, because they're information you might not have at your fingertips. One is I was really interested to hear, and pleased to hear, that the percentage of GP consultations for older people has increased, but I just wondered what proportion of that was taking place in person. So just be really interested to hear that, but perhaps that's one for after, to come back with some data. And just also really interested in what proportion we felt, if we have an estimate of professionals who are working with older people, are using the Aging Well guide. Just really interested in how what's its reach, how and where do we think there are still areas where perhaps it's not being used. Because clearly people who are using it finding it effective, and that's really good. So very positive thing. And then a more broad, I suppose, question, which in a way, I think you've answered it, but I think you'll know why I'm asking, which is really, I suppose, we have this funding, but I guess, do we have a sense in which we're making sure that we have those adequate community services, so that when people leave hospital, and we know that it's a fact that pressures on the NHS mean that sometimes people leave hospital and they perhaps have more needs than they might have in the past, or perhaps they've deconditioned in hospital more than they might have in the past, etc. I mean, how are we making sure that we have those services? And do we feel that the Better Care Fund, where that's being used as effectively to do that, and are there other ways in which we're doing it? Because I'm just very conscious that that's a huge issue, both in people's quality of life, their ability to be independent in the future, and then we see them then when people don't re-able and recover well, we see them then perhaps needing social care services sooner, earlier in their life, not being able to do the things they wanted to do and live the way that they would have liked because of that. So, and I'm just wondering how we measure. You had some outcomes in the presentation, but how we measure that whether or not we're doing as well as we might have done in the past on re-abling people historically, and making sure that people come home and are living that independent life that they want on the whole, but also that means that we don't then see them in long-term services with all that entails. So I know that's a complicated question, but there you go. Those are from me.
Do you want me to answer that now, or take other questions first?
Perhaps I'll take Beverly I'll take John and Beverly.
Right.
And then
okay.
we'll. John.
Thank you, Chair. Paul, from previous experiences, wheelchair clinic to discharge manager, to bed manager, to OT, to physiotherapy. How are you going to improve pre-surgery to prevent cancellations and after surgery to prevent bed blocking? My experience is like a car crash. I have heard what you've stipulated, and honest truth, it will not work. How are you going to implement something that's non-implementable from people that have experienced it? Thank you, Chair.
Thanks, John. Beverly?
Thanks very much. And thanks very much, Paul and John, for a really comprehensive presentation. It's really helpful to see the progress that has been made. I've got 2 points to make. The first one, I suppose, is the other sort of part of what Councillor Desnez has focused on in terms of discharge. Mine is more in the sense that if we're seeing more admissions with greater levels of multiple morbidity, do we need to be doing something different in the admissions avoidance space in terms of step up intermediate care, for example? And we may already be doing that, but is it sufficient to actually counteract the trend that we're seeing in terms of these admissions? And the second point is really to welcome the focus on carers and wholeheartedly agree that it's not just a local authority issue, it is a systems issue. We all know that carers bear the brunt of a lot of activity, sometimes unthinkingly, when we develop processes and pathways. Very often they're not as person-centered and family-centered as they could be, and therefore leaving families and individuals at a disadvantage. So it would be really good that we look to see how that improved investment can actually really support the well-being of carers in a number of different ways. Thank you very much for that.
Okay. So, Chair, should I?
Yes, please.
I don't know. John's got another question there. I think he put his hand up. I just thought I'd check before we.
Yeah, short and sweet, Chair. In the result of carers and what Beverly's brought up, I'm happy to bring this up separately. But if they could get rid of agencies whereby carers are rewarded and paid the money they deserve instead of agencies, I'm happy to liaise with Beverly privately with this matter later on. Thank you, Chair.
Thanks, John. So I think you're making a point about paid carers, are you? Is that correct?
Yeah, it's to get rid of agencies and pay them what they're rewarded. If the local authority could implement that, so agencies I've got rid of and carers are paid what they deserve, I'm happy to liaise with Beverly on a one-to-one to explain the whole situation a lot better and more professionally, or yourself, Chair. Thank you.
Thanks, John. So I think we were talking, I think Beverly was referring to unpaid and family carers there. But yes, I think that's a longer conversation, that one. But just to reassure, we do pay London living wage to all our carers, and there are particular structural reasons why we use care agencies, namely the marketisation of adult social care. And I feel like that could be a lengthy 3-hour discussion, but which we won't have now, but absolutely happy to have that conversation with you separately. So thanks, John. Paul, do go ahead and answer the other questions. Thank you.
Yeah. So I think a couple of questions tied up with community health services. So at some point, I'm hoping kind of Whittington are kind of going to chip in and talk through some of the specific details. What I think we're doing within this space is to try and understand what the resource base is. So this is an issue that's wider than the Better Care Fund plan, and is about kind of the amount of funding that's going into our community health services, to which the kind of the Better Care Fund plan contributes some of the funding. So we are looking at the moment as an ICB on the level of distribution of those resources between the different boroughs as well, because clearly we're a North Central London Integrated Care Board, and we've been doing that over a period of time. So over the last few years, we've started to get greater levels of investment within our community health services, and we've started to kind of invest in things like pain management and falls and so forth. So it is true to say that actually there's been an increased level of investment in our community health services over time. Now, that doesn't take away from the question you've asked there, Councillor Neves, which is about kind of matching that to kind of need. And that's some of the work that we're currently undertaking at the moment, about trying to understand two things. First of all, what the level of need is, and how do we measure that in a simpler way possible across the different boroughs. And then secondly, how do we match a level of resources around that to understand what the resource positions are around, not just for community health, I've got to say, but also in a variety of other areas as well. So we've set out some thoughts around that, and we want to kind of share that with councils as well, to see what the view is. I think the approach that we're trying to take has been positively received, and then we want to go a step further, which possibly begins to touch on some of the things that John is beginning to say, and I'll talk about wheelchair services in a second. But the idea is saying, well, that's fine, but actually, what does that mean, and how do we deliver services differently? So, for example, some of the thoughts that Whittington have had in this space recently are about maybe actually improving the levels of self-referral, but also supporting that through kind of innovation. I think kind of the idea of basically going out to residents more locally and saying, well, actually, instead of having a complex queuing system, which is effectively what the NHS often gets into, how do we kind of have a more sustained conversation around working with communities, which is really reaching in to understand what the needs are, because a number of these communities are kind of underserved groups and communities as well. And actually, how do we deliver that in conjunction with it? So this goes further than necessarily co-design, because co-design will kind of get you to reorganize some kind of deck chairs which are owned by essentially the kind of the NHS. We're actually talking about doing genuine co-production, I think, in this space as well. So I think we would be the first to say in the NHS, we are not real experts in this, and this is actually kind of innovation and exciting new stuff. But the idea of actually saying, how do we better manage our kind of existing resources better and make better use of it in a transformational way, is something that actually we're really looking at the minute. So we welcome conversations, for example, around carers in this space as well. So I just want to touch on the kind of the issue around wheelchair services, and if there are some issues there, I think that Whittington would welcome a conversation about how to improve its wheelchair services as well within kind of Haringey. It's something that we encourage. So if you're okay, I can maybe follow up with this call, because obviously it's our kind of community health providers at Whittington who would be really interested in the direct feedback around that. And then the Aging Well Guide. I mean, the Aging Well Guide is essentially, I possibly didn't make it clear enough in the presentation, is essentially a document not so much for professionals, but for kind of the public and for people affected by kind of frailty or multimorbidity in particular. So the messages there are pretty straightforward, but we also want to underpin that through arming kind of a group of staff, let's say a housing officer, with some basic messages about kind of helping people be fit and well and look after themselves as well. So it isn't just the Aging Well Guide, it's also about that training that we talked about as well. We do think that there are some areas that this has proved popular with, and our big burning need is to make sure that we reach into communities early, because the places it's been popular at the minute are places like hospital. Once somebody's in a hospital bed, and with all due respect, that's maybe a step too far. That's a kind of a step too late, and actually we need to kind of get out into communities and release those as well. So that we're having active conversations about that at the moment, and any thoughts that anybody had on this call, gratefully received, or follow-up conversations around it.
Oh, I think on that one, Paul, I think that's what I meant really. I don't think I expressed myself well enough. It was just that how are we confident that who's using it most? You've answered the question, is perhaps more at a hospital, who are we? Because we're obviously professionals, etc. I know it's available widely, but there's an opportunity when you see someone in front of you to say, "We have this guide. Do you want it?" So I think that was my point: is how far reaching is that? And it sounds like there's a bit more work that we want to do on making sure that. I think you're right. Housing colleagues, anyone who has contact with perhaps an older person.
Yeah, I'm just using that as an example.
They have a guide there that they can hand over, and so I think that was my point, and particularly within the council, I think it would be good to make sure that as a good starting point that everybody across the whole council, it's that thing of when you have someone in front of you, what are the things you might mention to them depending on who they are, and perhaps if it's an older person, that might be something.
Chair, sorry, just to add one sentence to that. Sorry, it's about also arming those individuals with the confidence and a little bit of knowledge about how to go forward with that conversation, because ultimately you maybe just want to translate that into kind of people changing some behaviours and so forth as well. So sorry to interrupt.
No, that's okay. So I had Nadine, and I did have Sharon, but I think Sharon might have slipped off the call. Perhaps she'll come back by the time you finished, Nadine.
I was just going to support Paul in answering some of the questions. There were so many, and apologies if I missed some of the answers now. The wheelchair feedback, absolutely, that's really helpful. I've already sent an email to Boshra to get your contact details, John, so we can have that conversation. There is self-referral for wheelchair services in Haringey, and they do meet their access targets, but there's always work to be done between discharge and streamlining the patients, making sure that whoever's in charge of your discharge in the hospitals make sure the referral has happened, which, often needs a bit of work. I was just thinking about the Age Well guide, and although it's been shared a lot in community services, I haven't seen it on any GP practice websites. So actually that's one of the actions I'll take for this, in terms of it being a bit more visible in primary care as well. And your point, Beverly, about the pre-admission, one of the problems with having rapid response to keep people out of hospital and turn them around at the front door, having multi-agency rising risk services, is that we keep more and more people in the community. So by the time those get to hospital, they are, by their very nature, much more complicated.
Yeah.
And hence then the length of stay goes up and they're more difficult. I think we'd always welcome ideas of what else we can do in that space, and we've tried to expand the delirium pathways and falls pickup services and things to prevent patients having to come in, but the more we do in the community, the more complex the admissions are inevitably going to be.
Thanks. Unfortunately, Sharon doesn't seem to have rejoined us.
I am here.
Sharon's here, yeah.
I can see you there. You had a question. Apologies.
Yeah, it's really a comment, really. I'm very pleased to hear that NCL is going to focus on co-production and co-production to a greater extent in relation to obviously the wheelchair service and other things. I just want to flag that I think there is quite a long way to go on this issue. As you will know, having heard some of the discussion recently at the Joint Partnership Board, there's quite a lot of scepticism as to how well-meaning we are, both so far as the NHS and the local authority are concerned, in relation to co-design, co-production, how much we value the time that people are putting into being party to consultations of various kinds, whether it's on the better care front or all of the things we've been discussing today. And there's a couple of particular issues at the moment, as you know. A lot of people have spent a lot of time over a number of years working in tandem with the council and others on the Osborne Grove nursing home project. That's taken many, many hours of people's time, and we've now been told, without any reason that that whole project is going to be scrapped. It's huge argument in favour of such a facility in the borough. It touches on a lot of people we've been talking about today. But we're being told that without any reason being given, that very important project is being scrapped. And people will be saying, well, what is the point of co-production if we give our time over years and years and years on a project to be told that it is going to be no more? On another maybe smaller but significant issue, we understand that the support for the Carers Forum has suddenly been withdrawn. Administrative support for the carers has suddenly been withdrawn at last minute. Now, that is not going down well, frankly. And these are things that perhaps we used to need to talk about outside of this meeting. But at the same time, I think it's important that we do underline the importance of even consultation, let alone going further on co-production, co-design, to all of these plans and all of these amounts of money that we are spending. They need to be developed in consultation with communities, and people shouldn't be kept at distance when we are developing these really important, strategic plans that are going to shape our policies over a number of years. We really have to mean what we say about co-production. So that's my main point I wanted to make, Chair.
Thanks, Sharon. So a few things there, and I think there's a few things there for me actually as well. I think you're absolutely right to raise the issue of the role of co-production and how we use it. And I think as here as a rep of Healthwatch, I think that's absolutely your role to do so. And I think there's something there definitely about how we maximise the role of Healthwatch in always keeping us aligned and keeping that work and aligned. And I'm sure Paul can comment on co-production, etc., within health context. So if I could just pick up on a few things you said there, because I don't think I want anything to be misrepresented either here at this meeting or in any other fora. So I think on Osborne Grove, I think what you said unfortunately is a little inaccurate, I'm afraid. Osborne Grove hasn't been scrapped. Any project is based on a business case, and if that business case doesn't stack up, we have to do something about that financially, and that's where we're at the moment. So the project is on pause because the assumptions that we made in 2019 don't hold true, and that's been shared with the co-production group, and we are going to meet and talk about what next and how. But yes, the project has been paused because we have a duty, if the assumptions that we made in 2019, which unfortunately is quite a while ago and quite a lot has changed, and we cannot shield, unfortunately, projects like that from all the changes that we've seen around us, both, sitting on the verge of a recession for many, many months, and the economy really flailing and failing. All of those things have real impact. So all of us are actually very upset about where that project is, and we've spent many months trying to rescue that project. So unfortunately, so that's really clear, and etc. I'm not sure about the admin support for the carers group being withdrawn. I do know that at the next meeting of the Carers Forum, they'll be participating in the review that we've been doing on the Joint Partnership Board and all the work that's taking place in order to improve what we're doing from a co-production point of view. And following on that review, which I think most groups now have participated in, we'll then be able to carve a way forward, which hopefully be as inclusive as possible, hear as many voices as possible, and maybe meet the needs both of the council and residents together to develop services jointly and also face the challenges that we have to face together. I think that's definitely the vision, and that's what's set out in the Haringey deal. So, and no doubt residents and etc. will continue to hold us to account on that front. So that's just my comments on a few of the points there. Paul, did you want to come in and say anything about co-production in the health context?
Yeah, so I mean, I think you're right. I think we've covered that about kind of learning how to do some of that work. I don't think that's necessarily something that the NHS has got a strong history of, but we need to build on what we're kind of doing and working on as well. And things like the incredibly, Arthur was incredibly helpful, the kind of public voice toolkit that was kind of produced. I know other partners contributed to it as well, is incredibly helpful. And I'd recommend anybody who hasn't seen it have a look through it. It's kind of very clearly set out the expectations of what we can expect with people who are maybe residents and patients, voluntary sector organisations, and also statutory sector partners as well, including things like remuneration. So it's well worth a read. We've certainly kind of are following it within our kind of NHS projects that we're involved with as well. But we've got a long road in front of us in terms of doing that. But we have got some promising kind of signs for things like the Inequalities Fund programme, where we've done some of that work, and we need to do more of that sort of work in terms of development.
Thanks, Paul. I'm conscious of time. I'm going to move us on to the next item on the agenda, which for some reason in the logic of your chair is actually item 9, and it's the Haringey Borough Partnership update. Rachel and Will.
Yeah. So I'm happy to do the brief borough partnership update, and we'll do an update from the Integrated Care Partnership Board. I'm going to be really brief. I'm sorry, I'm going to also need to leave promptly at 3:55. But I wanted to draw people's attention to the update that is in the papers. I won't share it. I'm just going to talk through a few key highlights. Since we last bought an update from the Borough Partnership, we have been doing a lot of work within our partnership boards, and I'll go through that in a little bit of detail. We've also been developing an outcomes framework and monitoring arrangements for Start Well, Live Well, Age Well, and neighbourhoods and inequalities. What we've been trying to do is to make sure that the work that we're doing, our project and programme work, is really able to be monitored so that we can do course correction and we understand the progress that we are making, and that we know which outcomes we are seeking to affect, recognising that it often takes a lot of project work to affect an outcome, and that all of those outcomes are contributing towards the North Central London ICP outcomes framework, because it's through that alignment that we make sure that we are all pulling together. You'll remember that we signed off at this board that North Central London outcomes framework, and I want to be really clear that the work that we're doing, we can monitor, we can evaluate, and that it's contributing. So I think that we're sort of seen as the outriders for that approach within North Central London. Will and his public health team have been very supportive of our development of that framework, and it's now being used as a bit of a model. In terms of the partnership boards, for Start Well, we have been hearing quite a lot about the new co-produced primary school speech, language and communications pathway that has been launched, that is moving us towards a universal speech, language and communications offer, which we haven't had before. So that's been really helpful. And we've also been focusing on our mental health and wellbeing provider landscape. So at the last Start Well meeting, we had all of the providers of mental health and wellbeing services for children and young people come to talk about what it is that they do in that space, and their challenges and what they're working on. For Live Well, we are in the process of mobilising a large-scale employment support programme, which is targeted towards people with long-term conditions, which is a very exciting piece of work. And Live Well is also where we have a focus on inclusion health. We had a big inclusion health summit on the 14th of September with a real focus on homelessness. And we have also been doing a lot of work on mental health ops, improving the kind of flow and our discharge pathways and processes for people with mental health conditions, particularly leaving hospital. For Age Well, Paul has covered a lot of the work that is happening, but a lot of positive work going on around reablement capacity, and around dementia-friendly Haringey, and as Paul referenced, evaluating the multi-agency care coordination team. In terms of neighbourhoods, so we talked about it a little bit before. There has been a real focus on getting practical, multi-agency, multidisciplinary working happening in practice. We've had a really good collaboration between the GPs, who are our neighbourhood leads, who are employed by the Federation, and our clinical leads for Start Well, Live Well and Age Well, really working together to try to make multi-agency, multi-professional working a kind of practical day-to-day reality. So each of our neighbourhoods has got a particular area of focus that reflects its demographic needs and priorities. So in Central Haringey, there's been a lot of work particularly focused on multidisciplinary meetings with psychiatrists, so that GPs can have direct conversations about patients who they are worried about with a psychiatrist. A lot of work to try to get that up and running. Multidisciplinary working around for children, particularly children with complex needs and issues in the east of the borough. That's been their real focus. And for the west, with its elderly population, there has been a lot of work around frailty and creating a frailty network. So at the Borough Partnership exec meeting, we were based at St Anne's. We went and had a look around and met with different staff from North London partners. It was really good to sort of get to speak to people and see new sort of systems working in practice. We talked quite a lot about Right Care, Right Person, which was due to go live that week, and people will know and remember that is the move from the police to withdraw from some of their areas of activity that are best led by health partners. And what came out of that and the discussion at the Borough Partnership Executive was really around some daily meetings that are monitoring impact and being able to respond very quickly, dissemination of information to frontline teams, and a task and finish group that has been set up so that we have a borough level conversation that's happening about implications. I don't think I'm going to go through anything else, but just wanted to note that I am really pleased we had a really good conversation about children and young people's mental health and well-being, where we really brought together a lot of our understanding of the services that are available, some of the challenges, so heard from the trust perspective, particularly around recruitment, workforce, known challenges like ADHD, waiting lists, and some of the measures that are being taken to try to improve that. We were able to also discuss some of the concerns, so concerns that primary care have and that social care have, and address that in a really open way and identify opportunities. So the Borough Partnership endorsed our focus on children and young people's mental health. We've had a lot of focus the past year on SEND and agreed that mental health would be a real focus for 24-25. And the other thing that we did was we reviewed and signed off our adults and older adults mental health plan. So that is a very tangible improvement plan. Again, we could talk about that for the whole meeting because there's a huge amount in it. And it is very clear on what our system priorities are for 23 to 25. and it particularly talks in the themes of early intervention and prevention, improved access to mental health care and treatment, and it sets out exactly what we plan to do. So that's really, really important from a continuity perspective. We now hold that plan as a system, and will be delivering on that. So the Borough Partnership Executive was able to review that and to endorse it, and noted the need to discuss the resources dedicated to that programme. Thank you.
Thanks very much, Rachel. And I know that you have a commitment with the SEND inspection, so you just need to leave when you need to leave. So I just thought I'd say that. Beverly, did you want to come in?
Yes, I wanted to come in, particularly before Rachel leaves, because at the ICP meeting yesterday, we had a sort of a mapping exercise, sharing the activity across the different boroughs in terms of their partnership activity. And I was sitting next to a desk, and I won't give the name of the council, but he actually said to me, "Is Haringey really doing all of that?" Because we had that really graphical representation of all the activity that's actually going on in terms of our borough partnership. So I really wanted to say a massive thank you, Rachel, because I know you're behind a lot of the leadership of this work as the borough director for integration, and I think it's exemplary in terms of the update you've given today, but also on a wider scale, the whole totality of the progress we've made as a borough partnership over the years. So just really want to say thank you for that.
Thanks, Beverly, and you speak on behalf of us all, so thank you very much, and thanks, Rachel and the team. There was something in there that you just triggered me, something that we might want to have a future conversation about, which is just about the Haringey perspective on the impact on the national medicine shortages. I've certainly had contact with some residents who it's been really obvious the impact. You mentioned, I know what it was, what triggered it was ADHD, so I know. And actually, I've seen it really firsthand. And I owe it to this resident to say I've seen also now when they've been able to get hold of their medication, that how life is back on track, but how serious that can be. So really interested that we might talk about that perhaps at a future session, and also provision for different kinds of pharmacies who do things like cut up specialist kinds of medications and all sorts of things like that. So just for a future, just wanted to hold that there, but feel like that's a really significant issue. And I'll be interested for us to discuss how much of an impact we're seeing and what that means for, I mean, it's people's lives, how they can live, but also their health ongoing. I don't see any other hands up. So, John.
Yeah, 2 seconds, Chair. Rachel, I can't admire your comment so much. I'm a volunteer for SAMS, which you'll probably be understanding, which is suicide awareness, suicide management, and a trained negotiator. The input you have just stipulated there, I've got nothing but admiration and respect. Thank you.
Oh, there you go. Thanks, John. That's nice feedback. I'm not going to quite end on that feedback. Unfortunately, Helena had to leave, but before she left, she had put something in the chat, and we don't have time to discuss it, but I do feel duty bound to just read it, because I think we might be something we want to pick up again when we talk about Start Well in future, and just hold it and respect the comment. And she had put a question in the chat just about how poor performance at North Middlesex Maternity Unit, and I think she's referring to the recent CQC report, will affect Start Well and what changes can be initiated. So I think I see Nena still here, so I didn't realise you were still here, Nena. So Nena, you might want to come in, but it might be something we want to pick up in a more lengthy way at a future session. I just didn't want to let that go since unfortunately Helena had to leave. Nena, do you want to come in just briefly?
Hi. I do, Chair, and apologies, my Wi-Fi is problematic. So can I check you can hear me? And apologies, I've turned off the video. Yes, thank you. I did respond to Helen in the chat. So just to remind that Start Well was very much about the level of neonatal services provided, and the fact that all providers of maternity services had level 2 apart from one in NCL. And that was the question that predicated what do we do with maternity services to ensure that we have the appropriate level of neonatal service to accompany it, so that the rating of CQC of North Mid is not germane to that conversation. And doesn't impact the review as is. I think there was probably a sort of subliminal question around, we haven't spoken about what that rating means for our women. And I think there's something around the fact that CQC has attended and downgraded many units across the country. And probably, as you say, a conversation for another day. But the one thing I would offer into the minutes now really clearly is that there is an inaccuracy that we have been unable to convince CQC to correct around stillbirth rates. And I want that in the minutes because I feel that's the one thing that might impact women's birthing choice to their detriment. The stillbirth rate quoted in the report was an in-month crude rate. That's not how we report. You have to look at the totality over a year in an adjusted way. So there were 2 stillbirths in 1 month, and that was what was calculated. The next month there was 0. The month after there was 0. You can't look at it in that way. And so it gives an inflated view of stillbirths, which in national benchmarking review is well within peer. So that's the one thing I would correct. But as you say, should you want a broader discussion about the improvement in maternity services, the reviews that have been done on maternity services, and most importantly, what we want to say to our women, happy to do so at a later date.
Thanks, Nena, that's really helpful. And I suppose one of the reasons I make the comments I made around outcomes for women with birth and their babies is because one of the discussions I've had many a presentation on Start Well, was around the ability to deliver services well when you have the right services in the right place, the right staff being trained, and the right staff having the right exposure to different, this is my understanding as a layperson, and the right exposure to the different experiences. So I feel like that's probably where the relevance comes from a little. But I do agree that it might be worthy of us giving this a little bit more time. And in Helena's question just prompts us to think about when and how we do that. So I will pick that up with the team around how we plan. But really useful to have your comments there and clarification. So thank you. Are there any urgent AOBs from anyone?
One point, please, Chair. Thank you. Yeah, in your inbox, Nadine. Thank you, Chair.
Thank you. Will.
Yeah, just quickly, ICP. So I know Rachel had to go early, but I was going to update briefly on the ICP, which I'll do in kind of 30 seconds. So the ICP is the Integrated Care Partnership at North Central London level. So it's the part of the integrated care system where the NHS comes together with councils and wider partners to look at how we're going to work together to improve the health and well-being of the population. So there's papers from the meeting we had in October or September, but we also had an ICP meeting yesterday. The themes that are coming out is how we work together collectively, because there is no formal blueprint of how we do this. It is all about relationships and how we establish working relationships at NCL between councils and NHS and other partners. And then how that working at NCL level links into the work that we're doing at Borough Partnership and how we use that to make sure we are assuring that work at Borough Partnership and we're adding value and we're tackling health inequalities, so that we're thinking through that. And it would be good to talk a bit more about that at the Health and Wellbeing Board at a later date about that link. And then some specific themes that are emerging. So one is around the physical and mental health of people across North Central London with severe mental illness, which really links into the work we're doing on the Borough Partnership on mental health. Heart health, particularly on high blood pressure detection and management and preventing people dying early from heart attacks and strokes. And then we had a discussion on admission avoidance, which we alluded to in the Better Care Fund item, and how we can do more collectively by taking a sort of population health approach to that. So I'll talk longer at future meetings, but I just wanted to note that the papers are from the earlier meeting in the pack, and we'll circulate the meeting we had yesterday, the papers as well. Thank you.
Thanks, Will. Really useful. And that last one, I feel, speaks into these two really important, much vaunted words, prevention or terms, prevention and early intervention, which, if I might say, are spoken about at national level, but I feel somewhat underfunded at national level or under-attended to. But so it'd be really good to come back to some of these themes and have a discussion about our response locally. I think we are closing now. Our next meeting is March I think. Is that right?
Yeah.
You have one before? No, March. It is March.
13th of March.
And I look forward to seeing some of you then and catching up between then and now. Thanks very much, everybody.
Thank you.
Thank you.
Thanks.
Take care.
Bye.
Take